We're taking a look at two fabulous joints, the knee and the ankle. But before we begin, let's get some basic terms, even if you think you know them, and you probably do at this point. But medial means towards the midline. Lateral means on the outside. And just knowing those basic words will help us to understand the medial meniscus of the knee. Here it is to the right. There it is. Well, Anterior cruciate, that is going to attach in the front. If we look to the far right, there's the anterior cruciate. So if we understand anterior, we know that the muscle is going to originate in the front. Femur at the top, tibia down below, fibula lateral side. We're looking at ligaments now that are over the joint, and they form that joint capsule that releases synovial fluids. There are the condyles, and this is an important articular site for the femur. And here is the tibia down below, the plateau, and this is all covered in articular cartilage so that we don't have bone grinding on bone. On the tibia, which is the lower leg muscle, we have a lateral, so there must be a medial articular surface. There's the patella, and the patellofemoral groove. There's a little space here. There's going to be synovial fluid. There's a fibula. It doesn't bear weight, but it still is important in stabilizing this entire joint, especially at the ankle. Let us take a look. Well, I think we'll move on here. A little review here. There's the patellofemoral joint, and the patella has been cut away. So normally the patella would be sliding right here in the patellar groove. If we look at the far right, we're looking at the back of the leg, back of the knee, and we can see the medial meniscus. It's a pad of cartilage. And the lateral meniscus. So we know we're looking at a right leg, right? Because we're looking at behind the person, and their right side is lateral. And here's the medial, towards the middle. We looked a little bit at this capsule, but I didn't talk about the retinacula, which we have medial and lateral. And if you look, here's the patella off on either side of the patella. This is just a tendon extending down from the huge quadriceps femoris muscle. It's going to help support the joint. There's also the patellar ligament. Here we have in the center, extends from the patella to the tibial tuberosity. So there's a roughened part, the upper part of the tibia. You can run your fingers across it, and that's where this ligament attaches. The oblique popliteal is, we're looking at the back of the knee, and this is a rather hard ligament to find because, of course, it's covered in muscle tissue. Collateral. Okay, collateral, think to the sides. There's the fibular, because look at, if you look to the far right, you see the fibula. There's the head of the fibula, and there's a collateral ligament, sometimes called the LCL. For short. On the medial side, so we're looking at the front. This is a right leg, medial. So tibial, often called the medial collateral ligament. We call this the MCL, but names do change over time. So this helps this biaxial, or excuse me, uniaxial hinge joint to stay aligned in one direction. These collateral ligaments are going to keep that side-to-side motion to a minimum. Intracapsular ligaments. Now look at that word. Intra means inside. So now while the MCLs are outside of the capsule, we have some important ligaments that are inside the capsule. So we have fluid in here, the synovial fluid. Let's look at the anterior cruciate. We know that it's going to attach in the front part, the intercondylar area, and extend to the posterior part of the leg. So the name comes after its attachment. It's going to limit hyperextension. Hyperextension is the word I'm looking for. And here we have it in the lower right. You can see what happens when the leg moves beyond anatomical position, we have disruption of those ligaments. Women tend to suffer more ACLs than men, and there's many reasons. There's speculation. One is the angle of the pelvis. You take a look at a woman has a broader iliac crest up here, and so a little more tension at this joint, although the body does adapt, so it's not drastically a problem. And also there's less space. We take a look at the far right. Here is the femoral condyles, lateral medial, and here's that space between them, and there's just less room for that. It restricts some of the movement of the ACL, but not a serious problem. The PCL, posterior, it's going to attach in the back of the leg from the intercondylar area of the tibia. So the tibia, here's the tibia, but I'm in the middle, and you can see the back of the tibia, and we have a tear going on there. It's going to resist posterior movement of the tibia when the knee is flexed, and that's good. And so it comes into work when we're walking down, especially. Now the PCL is similar to ACL, but it's a very thick ligament, and it may be injured if we hyperextend the knee, and that's a fairly rare injury. It's less common than the ACL tear, medial and lateral collateral tears as well. The menisci are articular discs. We looked at those earlier. Let's look at the lower right. You can kind of see the anterior view. One is sort of C-shaped, and the lateral meniscus more like a incomplete O. There it is right here. Lateral, medial. Here we have a top view. You can see the shape a little better. Now, these can be damaged, especially if there's a twisting action and it's weight bearing, and if your knee is bent. So all those together can contribute to a meniscus tear, or sometimes it just wears out over time, and that's a degenerative kind of tear. If you're deep squatting or if you're overweight, that puts enormous pressure. We can use arthroscopy to trim or suture down some of that tissue. The ankle joint, these names at first look bewildering, but if you look at the names, let's just take a peek here. Anterior talofibular ligament. Okay, it's anterior, it's the front. There's the talus, which is one of the largest bones at the top of the feet, and it's attaching to the fibula. So anterior talofibular. Here's the posterior in the back, talofibular. Right? Not so bad. And then calcaneofibular. Oh my gosh, it looks terrible. But here's the calcaneus, the heel bone, and it's attaching to the fibula. Calcaneofibular. Yeah. So if you know the names of your bones and you know positions, anterior, posterior, calcaneal, it's not so bad. That is the lateral. Let's look at the medial, the midline. Posterior in the back. Tibio, so we're looking at the tibia now. Talar. Talar is the top of the foot. Then we have the tibiocalcaneal, so tibia to the calcaneus, the heel. Anterior tibiotalar, so that's to the talus. And then the navicular, tibio-navicular, from the tibia to the navicular, which is one of the bones, anterior part of the foot. All right, the deltoid or medial ligament is really quite strong, and so we don't get many injuries in this region, and also it's unlikely you're going to move your ankle that direction. I'll go through that in a minute. So let's look at sprains. Different types. We have grade 1, we have micro tearing, and often there's no problem here. It's going to repair really quickly. Then we have grade 2, where we have some tears, but they're incomplete, and there's some difficulty bearing weight. And then grade 3 is where there's a complete tear. And the grade's different in the ankles because when we have the lateral sprain tends to just be a tear, and that's when we invert the foot. And so, and there's plantar flexion. So let's think about this. Your ankle's turning outwards, inverting outwards while you're bearing weight, and the heel's off the ground. And when that happens, you're going to get some hemorrhaging, perhaps. So you get the bruising, purplish color, and accompanied by edema or swelling. Now, there's a lot of treatment plans, and but cold packing early seems to be wise no matter what, because you're going to reduce the edema, and the cold will sort of temporarily deaden some nerves so that the pain's not as intense. And then after a few days, heat perhaps to get some flow of platelets in there and some repair. But everyone's different. Every treatment has to be sort of tailored to that individual. There's Carrie Strug, Olympic gymnast. Let's look at the medial side of the foot, and these are very powerful ligaments if you recall. Tibiotalar, tibiocalcaneal to the calcaneus, tibionavicular, tibiotalar there. The more we hear them, the more we say them, the more they start to make sense. Posterior, anterior. All right, medial I mentioned, it's not very common. It's a very strong set of 4 ligaments. And also there's a less likelihood. Let's look at these ankle sprain positions, upper right. Inversion, that is where the, sorry, I'm having trouble with the pointer there. The ankle is going to be turned outwards. Excuse me. Yes. And eversion, because I'm looking at the toe here, this is the toe, is when it's an inward turn. I got this picture of a Green Bay running back, and that probably shows it better than all my talking right now. Is you can look, and there that ankle is being driven down to the ground, and that is definitely a medial sprain that is going to cause problems. What happens sometimes is these ligaments are so strong, they're going to pull a piece of bone away from the malleolus, medial malleolus of the tibia, rather than tear. That is testimony of the strength of these 4 ligaments. And so we have a chunk of bone that has been pulled away, and now a surgeon needs to get in there and reattach it. See, whereas a lateral tear is often we just ice it, then some heat, and rest it, and we're good to go. Here we may have to go under the knife. All right, thanks for listening.